active shooter, I'm not going to go over like how to go in there and take out the shooter and all that sort of stuff. You guys know probably the basics, right? What do they tell you the basics? If there's an active shooter, run, hide, fight. You guys all know that? Okay. We're not going to go over that because you all know that. What I have on this paper is what to do if there's an active shooter or a terrorist or something happens and the scene is now calm, which means the shooter is in custody and gone, or he ran away, he's nowhere near, or there was something going on, and the scene is clear. You guys can go into this scene. You may have people, you know, wounded in bonds. You may have somebody at the library doing a city council meeting. The shooter ran away. Or there's no more threat. Okay, so we're not going to talk about what to do when there's a threat there, other than run, hide, fight. We're going to talk about what you could do as a medical person, or as a DRT person, or as a private citizen. So I'm going to go through this, and then if you have questions, let me know. All right, so this is an algorithm I made, and actually I modified it for tonight, but there's something very similar like this I made when I teach law enforcement what to do. Because law enforcement doesn't want to depend and wait till fire comes in, because it'll take too long for fire to get there. So law enforcement wants to get in there and start saving lives. First thing, prep. PPE. For you guys, what would that be? Gloves, yeah, gloves. For law enforcement, what's it going to be? Ballistic vest, ballistic helmet, those types of things, weapon. Also need some medical supplies. Whatever it is, whether it's a medical kit or it's a bandage, you know, a bandage and a tourniquet, whatever. You need to have, if you can help people medically, you should have medical equipment, obviously. And then stretcher. And it'd be nice to have stretchers. You get a lot of people when you have to back weight them out. I don't know what kind of stretcher you guys have. There's a lot of different ones in the market. But something that's lightweight, and you can throw somebody on it and get them out of a danger zone. Okay, so that's the prep part. And then you do scene assessment. I know you guys probably all know scene assessment being on the DRT, right? Hopefully. So what do you, additional suspect. You always have to be alert. Even if the suspect ran, he's gone. As I'm going, I'm kind of just being aware, right? I look around in case they left a bomb, or like, let's say there's another suspect. And when we do these trainings, what we usually do is we have a shooter going, and then we have the first team go in there and actually take the shooter out and kill him, and then we bring the medical team. What we always do is we always put a gun on somebody. Just, you never know, there may be more than one suspect, right? So, if I'm helping people and doing stuff, and I look at you and you kind of look a little, you know, shifty, and I'm not sure, you may be another suspect or something like that, you know, I may walk up to you and go, sir, are you okay? You hurt anywhere? Are you shot anywhere? You know, it looks like you're doing okay. All right, we'll get some help for you. What I just did is just frisk them. If I felt a gun, I could get out of there, or I could do something or something, you know what I mean? So we're always searching people without knowing that they're being searched. We're just looking for, hey, sir, you injured anywhere? You hurt good? Okay, you know? So we're kind of doing that. So we just want to be aware in case there's an extra weapon, extra gun there. Now, not everyone that has a gun is a bad person, right? This gentleman may have a CCW, a permit to carry a gun. He may just carry a gun as a citizen. So just if he has a gun on him, I'm not going to think, you know, I'm not going to try to shoot him or hurt him or something like that. He may be allowed to carry a gun. But just be aware of those things. That's some of the things we do on scene assessment. You know, sound of gunfire, if you see an IED or a bomb, there's a fire, HAZMAT, some people may leave some chemicals behind. All right, so if it's not safe, you're not going to go in. That's pretty basic to DRT, right? We don't go into an unsafe scene, right? Because if you get hurt, there's kind of a double negative that happens, right? In a disaster, we always want more rescuers than victims. If we have more victims than rescuers, and we're overwhelmed, what's that called? It's called a disaster, right? Your resources are outnumbered by your victims. So we never, as a rescuer, want to get hurt. Because right now, I'm a helper. If I stayed home, that'd be better than me getting hurt. Because right now I'm a helper. I put me in the helper column. If I get hurt, I'm taking me out of the helper column and I'm putting me in the victim column. There's actually two things that happen, right? It's not just removing somebody, it's putting them in the bad category. So we don't want, obviously we want to take care of ourselves. All right, next thing, find victims. That's not as obvious. Now, if there's an earthquake, you don't have to find the victims. The victims can come out to you, right? If they can, they're going to talk or yell, or you're going to walk in and you see someone hurt and all that sort of stuff. It's easy to find victims in an earthquake. In a terrorism situation or an active shooter, it's hard to find victims. Why? People are told to hide, right? If you can't run, hide. So when we do our active shooter drills, We walk in, and I have some mannequins set up as bodies, and I have some goulash people. We also put people in cabinets and under desks and stuff like that. You sometimes have to look for people. Hey, I'm a DRT medical. Is anyone hurt? Anyone hurt? And I don't see anybody in this room. There may be people hiding under things because they don't know who I am. You know, they're scared. So it gets a little more complex when you're dealing with terrorism. You have to look for your victims sometimes. They are hiding. They are scared. Okay, so we found our victims. We had to make a quick determination, dead or alive. That's it. If I go to, and I'm going to go to first person. If I come up to you and you look dead, you're done. I'm moving on. If I'm not sure if you're dead, I'm going to feel for your pulse. Right? I mean, if she, you know, if she were to have a fatal injury, a gunshot wound to the head, she's not moving, all that. I mean, you know what obviously dead looks like. But if you're not sure, just check. Once we determine someone's dead, we're done. We're done with them. We don't do anything. Move on to the next person. And if she's alive, if you look at your list, the first thing I'm going to do is mental status. Now, I don't know, like in first aid class, they say, you know, airway, breathing, all those things. No, we don't do that in disasters. First thing is the mental status. If she's able to talk to me, that's going to help me out a lot. I say, what's your name? You know what's going on? And she goes, yeah, what's happening, and stuff like that. If we're able to have a conversation, there's a couple things that can happen. One, I'm going to ask her some questions. How many shooters were they? What were they wearing? Which way did they go? Right? She says, I think there was just one, he went that way. Then I'm going to feel a little more safe. If she says, I think there were two shooters, one ran that way and one's still in the building, well, that kind of changes things. I'm going to probably leave the building. So I kind of want to know. The other thing is, if she is alert and she's bleeding, I'm not going to bandage her. I'm going to hand her a bandage and say, here, don't pressure on this. Right? So people that are able to understand things can take care of themselves. They're managing their own injury. I don't want to hold pressure on somebody who's bleeding when they can do it themselves. Or if she's kind of a little confused and bleeding and you're fine, saying, you know what, you just hold bandage on her, you got help coming, hold pressure. So that's why I want to know what their mental status is. Also, if I think there's a risk in this building, like the shooter's still here, or there may be a bomb or something like that, if you're awake, I can tell you, don't go out that door and run. If you see police, put your hands up where they can see them, because they're going to think you're a suspect. Just do what they tell you, just go out that door. I don't have to worry about her anymore. If you're totally confused, I can't tell you to go out that door. You don't know what's going on, or you're unresponsive. That becomes a problem. So people that are alert, oriented, can take care of themselves. They can lead. They can follow directions. It makes my life so much easier. Next thing is bleeding. Extremity bleeding. We already talked about that. Direct pressure, that doesn't work. We're going to tourniquets. And tourniquets work again for extremity injuries.
Mark, can I go back to something you said? She said she thought there was another shooter in the building. She didn't know where. Would you tell her to leave? Would she be exposing herself?
You know what? I'd have to make that determination.
Yeah.
Realistically, I'd probably leave it. She'd be on her own.
Yeah.
No, I don't know what I would do in that situation. The best situation is that you guys are going to stay away from a crime scene until it's determined that it is safe by law enforcement or somebody determines it's safe. Then you go in and do the stuff on the sheet. If part of the scene assessment, if I think there's a shooter in here, I'm not going in. That's my scene assessment. I'm not going in. Because if I'm outside, I'm thinking to myself, okay, you know what, I'm medically trained, I'm on the DRT, I could save someone's life. You know, I'm waiting to help, right? If I go in and get shot, then I'm out of the picture. I can't help anybody. So yeah, this is really designed when we have a pretty good determination that it's safe. Now there could be a bomb, there could be another shooter, but we're going to hopefully use this when it's safe enough to go in. Abdominal wounds. If someone's shot in the belly, they just need to go to the hospital. There's nothing you can do for them. We can't pack wounds, we can't put combat gauze in them. There's nothing you can do for an abdominal wound other than go to the hospital and get them to the operator. Okay? And they don't bleed a lot. If you get shot in the belly, you're not going to see a big, huge pool of blood. All the bleeding that's occurring is inside the body. Matter of fact, most of the gunshot wounds I see at USC, they get shot in the belly. There may be a little tiny bit of blood just running out of it, like just kind of just oozing out of the hole. All the bleeding's inside the body. So there's really nothing we can do. We have to go take them in the operating room, open them up, and stop the bleeding. Okay, so there's really no treatment for them. So they're really priority cases. That's why I said internal bleeding, rapid transport. If they, how do you know they're internal bleeding internally? If they have a hole, and they're pale, and their pulse is real fast, what does that mean? They're in shock, right?
Mm-hmm.
What's the quickest way to tell someone's in shock? Is it a fast pulse? Anyone know?
Sweating, huh?
Sweating, fast pulse. Fast pulse is the earliest indicator of shock.
Tachycardia?
It's what?
That's tachycardia?
Tachycardia, exactly. A pulse over 100 is tachycardia. So that's the first sign of shock. Okay, now I'm going to throw some out to throw everybody off, confuse everybody, because medicine's not really simple. There are a lot of people in this community that have high blood pressure. And there are people who are on drugs with blood pressure called beta blockers. If you're on a beta blocker drug, those are drugs that usually end in OL, like labetalol, propanolol, things like that. If you're on one of those drugs for high blood pressure, you're not going to get tachycardia. So if you wait for somebody to have a fast pulse rate to determine they're in shock, you're going to miss shock. If they start getting pale and sweaty and weak and dizzy and all that, they're probably in shock. Because those drugs prevent the heart from going fast. The whole idea is to keep the heart going slow and calm to lower that blood pressure. So that's it. Like in the military, you teach people tachycardia, right? Because in the military, they're all young people, young, healthy people. So we look for tachycardia. Now when we're in the civilian world, we may miss that because of people being on these high blood pressure drugs. So just sort of throw out there just to help predict things. Clotting agents, does anyone carry clotting agents with them? Like combat gauze? Okay. There's 3 places that you would use that. Okay? You're not going to pack a belly with it because it won't do any good because the bleeding's internal and all that. There's 3 times you want combat gauze. One is if you have an injury here that's bleeding internally or externally, like in this area here, in the groin, because if it's in the groin, you can't get a tourniquet on it. So the only thing you can do is either pressure or combat gauze. If someone gets shot in the armpit, I can't put a tourniquet here. The tourniquet's not going to do anything, you know? So it's either direct pressure or combat gauze. You get shot in the neck, direct pressure, if that doesn't work, combat gauze because you can't get a tourniquet around the neck. Those are the only 3 places in the body you would ever need to use combat gauze. Okay? There's other things too. If somebody's on like blood thinners and they're bleeding out, you could use combat gauze. You don't really need to. If you're on blood thinner and you're bleeding somewhere from the extremities, you can manage that by direct pressure. That's not a big deal. But these 3 spots are where you need combat gauze. So some of you may carry it, some of you don't. Which one do you carry?
Quick clot powder.
Okay.
I'm not sure the name.
Okay.
I used to quick clot.
There's I think the most popular one is Quick Clot Combat Gauze,
Yeah.
and then there's another one called Self-evac, which comes in a white package. And they're both fine. They work differently. They're both fine. The only thing with this, if you carry this, if somebody's on blood thinners, this doesn't work. So I carry this and I carry Self-evac. Self-evac will work if someone's on blood thinners. This does not work for on blood thinners. So most people aren't. So I mean, it's not a huge thing. If you go use it doesn't work, that's why the program couldn't work for it.
So what do you recommend for people in blood thinners?
It's so-called Celox, C-E-L-O-X. It's granules, and that will it works on a different mechanism, so it doesn't matter. Where are we? Spinal mobilization. That's a whole talk in itself. Just so you know, everyone who was in car accidents that gets put on backboard and collars, we in the medical world have known forever that that's overkill. You don't need to do that. It takes a lot to break your neck. But the fire department's always paranoid about missing a neck injury, getting sued and all that. Now we're finally getting the fire department less paranoid. Actually, very rarely do we put people on backboards. It's very rare. Unless you're in a major accident and you have numbness or tingling in your hands and your neck hurts and there's a good indication that your neck's broken, we'll put you on backboard. Otherwise, we just put a C-collar on, a cervical collar like that on somebody, and just restricts their movement. And, so we don't. So if there's a disaster and you're not going to get help for a few days, don't just somebody that fell off a ladder or somebody that has neck pain. Don't be so quick as putting them on a backboard, because there's actually more damage on putting them on a backboard. So it's really hard to break a neck. If someone's on a roof and an earthquake happens, they fall off the roof, they land on their head, yeah, put them on a backboard and immobilize them and all that. But in general, low-speed car accidents, ground-level falls, most things like that, it's really hard. They generally don't break their neck. And the problem is, if you put somebody on a backboard, okay, here's a disaster, help stays away, right? You put somebody on a backboard and strap them down. Now what do you do with them? There's complications. It's called hazards of immobility. If you immobilize somebody who's over like 50, 60 years old, you keep them on a board, you wait for help to come, it's going to be a day or 2 out, guess what? They're going to develop blood clots. They're probably going to throw a blood clot to their lung and kill them. So there's a lot of problems. Somebody with what's called COPD, which is a breathing problem, or asthma, or congestive heart failure, you can't lay these people flat on a backboard. They won't be able to breathe. So there's a lot of downsides. So before you put somebody on a backboard, you really have to determine, what are the chances that their neck is really broken, and what am I doing once I'm on the board? So that's a big thing. We're really trying to get away from that stuff in disasters. And by the way, gunshot wounds to the neck do not require mobilization. Okay? When people break their spinal cord or break their bones and injure the spinal cord, it's usually blunt trauma, like a fall into the head, a fall into a swimming pool, a car accident with severe motion. It's all those types of things. Penetrating injuries, if you're going to have spinal cord injury, penetrating injury, it's going to happen right then. Right? The reason we put collars and backboards on people is, if they have a broken neck, is to prevent them from moving too much and possibly damaging their spinal cord. If you get shot in the neck, either your spinal cord is going to be damaged or it's not. If the bullet breaks bones or does stuff and you move around, they're not going to get worse. So we don't worry about that with penetrating trauma. So if somebody gets a gunshot wound, don't worry about mobilizing the neck. We don't do that. That's old school. We stopped doing that. Chest wounds. If someone has a big hole in the chest, we want to cover with an inclusive dressing. If they have a lot of shortness of breath, something like Vaseline gauze, or just something like Saran wrap, or just something like that. But that's only required for holes about bigger than a nickel. Small holes, you don't need to cover. Airway, try to keep it open as best you can. I mean, we don't have any advanced airway stuff, so generally it's not a huge problem. If they're in shock, you can elevate their legs. Most legs are just really broken. Then the last thing, I'll finish up the next minute or two. Cardiac arrest. Anytime if you go take a Red Cross course in disaster management, or anytime you talk about disaster, we always want people to learn CPR and have CPR cards and all that. Just so you know, in real life, we never do CPR in disaster. Because the outcome of cardiac arrest is very, very slim. And if there was a big disaster in Florida, whether it's an active shooter, a bomb blast, or earthquake, if you guys were all my victims right here, if I did CPR on this person, their chance of surviving is nil. And so if I were to do CPR on her while 4 of you bled to death, that would not be very wise or useful. So we do not do CPR. And it's funny because all disaster courses include CPR. I know probably a lot of you are CPR trained, and that's good for everyday life. In disaster, don't do CPR. In a hot zone, an active shooter, cardiac arrest, we don't do CPR. If paramedics get called, there's been a shooting, and you have one victim who's bleeding and another victim in cardiac arrest, we do not work on the cardiac arrest. They're dead. We work on the bleeding. So overall, if someone has a cardiac arrest, their chance of survival is 10%. That's it. 90% of people that go into cardiac arrest will never survive. We only save 10% overall. If we have an AED close by and we can use it within the first few minutes, the survival goes up to 30%. So we can triple our survival with an AED, but overall it's 10%. If someone's in cardiac arrest due to an injury, car accident, gunshot wound, anything like that, survival is 1%. 99% of people. If you see somebody on the news and they're in a car accident, you see them do CPR and on the way to the ambulance and all that, they're dead. 99% of people in cardiac arrest from injury do not survive. The public doesn't know that. So, but what we do is, in the county of Los Angeles and most counties, if someone's in cardiac arrest due to an injury, we don't do anything. Matter of fact, LA County's policy is that if someone's in cardiac arrest from an injury, we just pronounce them on scene, we don't transport them. So just so you know, that's the reality of it. So if you learn CPR, that's fine for your everyday life, but don't put your energy into something that has a 1% survival when there's a lot of other people that need your help, that are bleeding and have other problems with shock and people going to labor and all sorts of things. Crazy things that happen in disaster. So just a little side note on that.
Good question. So,
That's not a good question.
So there's two approaches to it. If we're dispatched as a team versus if we're a civilian responding, because I'm assuming you're dispatched as a team, you triage and start, or you stand and you start triaging first, then later come in as medical, then later treat. But is that right? You treat, but then if you were just as a civilian, I came in, so I just started treating the first person I see, or how would you approach it?
Just in general, not talking about cardiac arrest, just in general?
That's in general.
Okay. Does everyone know the STAR system?
Yeah.
Raise your hand if you know what STAR system is, for sure. Good, perfect. Glad you guys know it, because in about a year or so, it's not going to be here anymore. Just so you know, don't tell you reality stuff, STAR does not work. It has been proved in disaster over disaster that in the STAR system, what you would use your algorithm and label people, they could be like way close to death and they'll get tagged as delayed or minor because of the STAR system, the way it works and set up. It's been proven and it doesn't work. So there's a push in the United States, actually, countrywide, to get rid of the STAR system and replace it with another system. And those of you that do know the STAR, that do understand the STAR system, the way STAR system works is I come up to you, the first person. Well, at first I make an announcement, those that can walk it out of the room and all that. So I'm going to go to the first person, and I'm going to do 3 parameters I'm looking at, and I tag you. I go on to the next person, 3 parameters. If you're bleeding, by the time I get to you, you're dead. That's one of the reasons STAR system doesn't work, because you start with the first person and you work your way. And so that's a big problem. So it's being replaced with a system called SALT. And the way SALT works, and you're going to see this coming up really soon, is SALT stands for sort. And what sort means is I'm going to walk in the room and say, hey, those of you who can hear me, those of you that like to walk, go out and go into the parking lot, helps coming. Kind of like the beginning of triage system. Okay, that's the S, sort. Okay, now I've got everybody left in the room who can't walk, right? A stands for assess. And what does that mean? That means I'm going to stand here, and if I see that gentleman back there is bleeding, is a pool of blood, I'm going to him first. If I see that you have a bullet in your head, there's blood around you, and you're not moving, I'm not going to you. That's probably a fatal injury. If I see you, sir, are just sitting there, breathing fast, and you're all pale, once I stop the bleeding, I'm going to you. So start, instead of going one by one while people in the back row are dying, because you're in a bad place tonight, you should be up front, that's why that doesn't work. The A stands for assess. I'm going to look around the room and see who's the 6th person and go to them.
You prioritize.
What's that?
You prioritize.
I prioritize, exactly. L stands for life-saving treatment. Okay? Now, START is really designed to just tag everybody.
Right.
Well, if I see that you're bleeding out and you're in shock and I tag you as immediate and I leave you, I'm going to help you, right? So once I go in there and I assess for the most serious, now I'm going to do life-saving treatment, which means if you're bleeding, I'm going to put a tourniquet on you, sir. If you're pale, I'm going to lay you down and elevate your legs. Does that make sense? I'm going to, if you have a noisy airway, I may try to open your airway. I'm going to fix these problems in priority of what's life-threatening. And then T is transport. They can get them out after you've done that. So it's taken away from pointing to one person and just looking around the room and say, who needs my help right now? You're thinking to yourself, and you're going to go to those people. So it works. It's been proven, it works. We're expecting it to come out soon.
Well, I think Evan helped us out. We just did our field manual everybody got a couple minutes ago. I believe, Evan, you updated the manual for that. Is that true? Did you add salt? We took out START and put in salt?
We took out salt just because of the.
Okay.
We took out salt or added some?
Yeah, we took it out because we were following the LA County and Ventura County.
Right, they use START, but
yeah,
they're going to be told very soon not to use it anymore.
Okay.
Because it doesn't work. It's been proven it doesn't work. So you'll probably go back to the salt. They're trying to make it a national standard. So the counties don't get to decide, it just becomes a national thing that everyone's using that system. And that works way better in any situation. So if you look at this, it's pretty, but I determined it's safe to go in there. I'm looking for my most serious people, you're live, I don't see a major injury, are you okay to go out there? And if you're not responding or they feel close to you, I'm going to leave you. And I'm going to look around and who's bleeding? Bleeding will kill people. If you take first aid class or EMT class, they always say number one priority always is airway, right? ABCs, airway. No, we don't do that anymore. Tactical medicine, emergency, disaster stuff, airway is not number one. Bleeding is number one. If I cut off your airway, sir, your brain's going to start dying in about 8 minutes. Okay, you'll be brain dead in about 10 minutes if I totally cut off your airway, right? You'll start brain cells dying in about 8 minutes. If I tear your femoral artery, you can be dead in 3 to 4 minutes. Bleeding takes precedence over airway. And so in tactical medicine, that's what we're teaching, and we're actually teaching it, and so people that are in the medical world are starting to get in their mind, okay, airway's not number one anymore, it's bleeding. Because with an airway issue, we have 8 to 10 minutes. With bleeding issue, we only have a few. If you're on anticoagulants, we even have less time. So a lot of the stuff that you may have learned or read about, it's being changed. And then now we do evidence-based medicine, we look at these things that we've done all these years and say, hey, let's look at the outcome, let's actually look at these cases and see what worked and didn't work, and let's change things. Yes, ma'am?
Will they eventually be trickling that down into the CERT program? Because at this point, we can't really do that because of
I
the
hope so.
guidelines to CERT. I hope so, yeah.
CERT's a good program, I don't want to knock it, but it's developing people that are not really medical, who don't do disaster management. Some of the instructors of different CERT programs are people that are hired by the fire department as various things, they've never actually done anything. And so so there's a curriculum they have to follow that.
They're teaching theory.
What's that?
They're just teaching theory, they haven't had practice.
Yeah, teacher theory, right. It's kind of like if you go to a Red Cross first aid class, you're going to learn first aid, but if you want to become a Red Cross instructor and you don't have a medical background, you can become a Red Cross instructor. You take the basic first aid, you take advanced first aid, and you take the instructor class, they give you the curriculum and you teach it. Right? So you're not going to deviate from it because you're going to teach what they tell you to teach. So it's kind of the same thing, but we're trying to get out there kind of like the evidence-based stuff and what we know medically, and it's slow. Anything in government is slow to move. So when we switch over to the SALT system, when we start allowing, blind people to have tourniquets, when we start doing all these changes, it's very slow. When we told paramedics you don't put a collar on or backboard on somebody with a gunshot wound to the neck, boy, it took a long time. They didn't like that idea because they grew up with always doing that. And it's really hard now. If you're in a car accident, you come out of the car and you're walking around the scene, you don't need to go on a backboard. That's really hard for the paramedics to do that. They're not used to that. They're used to putting people on backboards. So it's just kind of slow to do. Any other questions? I've probably taken way too much time. I know there's another speaker. Are you the other speaker, sir?
Yeah.
Well, I'm sorry if I took up your time. Does anybody have any questions before I end this? Okay, I hope that we'll see you guys do some drills so you can actually do some stuff.
Thank you very much.